everyone. Welcome again to Sihat Beyond the Clinic podcast. I'm Dr. Vicky and we have Dr. Ame and we have a very special guest today, Manvir Victor, a distinguished figure in Malaysia's media and healthcare advocacy sector. A former celebrated media personality, he transitioned to healthcare advocacy as the founding chairman of Patients for Patient Safety Malaysia. In this role, he has spent over 6 years advising healthcare organizations on effectively integrating patient perspectives into their operations. Manvir serves on the Malaysia National Patient Safety Council, and holds an international presence as a board member of the WHO Global Advisory Group on Patient and Family Communications. Additionally, he contributes to global discussions on healthcare through his role on the British Medical Journal's Patient Advocacy Panel as the host and producer of the podcast Healthcare Simplified with Manvir Victor. Heard in over 15 countries, he advocates for healthcare providers to prioritize patient engagement, improve systems, and adopt innovative technologies to enhance care delivery. So welcome to Sihat Beyond the Clinic, Manvir Victor.
Glad to be here. Yeah.
So today, the SBTC team actually reached out to Manvir because we wanted to cover something that is not covered enough in Malaysia, which is the aged care community. Okay, so let's set the scene. Malaysia is projected to become an aged nation by around 2030. Okay, so around 15% or more of our population will be at the age of 60 and above. So from where I see it, we have a lot of aged care services going on in Malaysia. However, demand is already outstripping what families and the system can provide. So what are you seeing as an issue from the public health perspective, Dr. Amir?
Well, Vicky, the demographic shift is in the headline, but the real story is our health system was built for our young population, with mostly acute infection diseases. You can think of malaria, TB, maternal and child health. So we're doing brilliantly on that. We're covering that side very well. But we haven't rebuilt the system for a very special population that's now living with longer age ranges. We also have chronic conditions that overlap with other conditions as well. So aged care in Malaysia, as you know, is considered a private care actually, and rather a family responsibility. But not a public health infrastructure issue.
Yeah, so we do have Pusat Jagaan Warga Emas in Malaysia. So, Mr. Manvir, I think this is the time for us to bring you in. You have spoken with hundreds of patients and families through Healthcare Simplified and Patients for Patient Safety Malaysia. Can you share with us any story that can, correlate to you personally about someone who is aging?
Well, thank you for having me. Of course, for me, the stats that you just shared is quite frightening because next year I turn 60.
No. You go into the stats.
I go into those stats, right? And that's what aging is one of the things in can't stop. And we have to still care, we still have to mitigate for it. So I'll just give you an instance of something that happened to us. My late father-in-law.
A personal story.
Personal story. A couple of years ago, he was in his 75, 78, around there. And he had a mild stroke. And then we ended up in hospital. And after that, he needed the care, right? And so that's when we had to start shopping around and looking around for facilities where we can put him in. And we found that there are so many facilities, not enough, still not enough. But the problem that we have is there any guidelines to set this up? And me being in healthcare in this area, I always was trying to find out, are there guidelines, are there regulations, who's regulating it, what is the standards that we are meeting, are we doing all these things correctly? Now, I'm on the Malaysian Society of Quality Health Board as well, so they do accreditation for hospitals, right?
MSQH.
So, MSQH. So, a simple question I'm asking is, are these facilities accredited? Is there a base standard? Is there a foundation? And then suddenly I find out that no, there aren't any, right? So, which means that you can put your loved one into its home and then What is the care like? Is there going to be a doctor there? Are the nurses trained to take care of this? And they're all human, right?
Yeah.
So if there's no proper guidelines, you'll find that a lot of people will send their family there. Now, my late father-in-law passed away soon after that. So we didn't put him into a home. But I've got a lot of friends, family members in the same age group, and they've put them in, and there's been horror stories. There's horror stories because there's no guidelines, no regulations, but there's no standards. And this is not what we want to do as Asians, right? We want to take care of our elderly, right? And suddenly you take the elderly and you put them in this home, you don't know. You absolutely don't know whether the person is going to be safe. Are they going to be cared for? Are they getting the right medication? If something happens to them in the middle of the night, are they going to be cared for? Because, so you keep thinking of this and then you're paying good money, thousands of ringgit to get this done, but you're not sure of the standards. And then you have these facilities. And I started to call them fly-by-nights. But why I do that is because they don't have a strong brand name. So if something happens and, you want to complain, who do you complain to?
Absolutely.
Yeah.
Who's regulating them?
Who's regulating? How do I complain? I want to sue them. How do I sue them? What is the standard they are at? You understand? So we are taking a huge risk by putting family members in spaces that we are not sure itself. Would you like to be there yourself? No, because the nurses or the caregivers are going to shout at you. You don't know any of these things, and then we are busy at work, 7 days a week, 5 days. You go there for 2 hours, everything looks fine and dandy. And then when your family member tells you there's something wrong, so you ask yourself the question, right? And what can be worse is if the family member has dementia or something.
Absolutely. They can't recall anything.
So you're thinking, hey, how is what the person is complaining to me, is it true or not? I don't know. It's a figment of their imagination. So this is where we really need to do better. We need to regulate them. We need to look at them. We need to have standards of these because these are our family members that we are entrusting in this facility. Obviously, we don't want to have regret later. So this is where I think people in this, whether it's the Ministry of Health or the Ministry of Welfare or whatever, they need to look after the well-being because even their parents will end up doing that, isn't it?
Yes. I think there's an aged person in every household right now. I think everybody can relate to what Mr. Manvir just stated. Being an Asian from Malaysia, there's a strong cultural piety framework across caregiving, the term caregiving. That means if somebody old gets ill in the family, naturally, it's a cultural expectation that the caregiver should be from the family itself. That means without being appointed officially with an official letter, black and white, it's an automatic. If your mom or dad suffers a stroke, or your mom or dad or somebody in the family goes through cancer, for an example, the caregiver should be from the family. And if the caregiver is not from the family, then there's a stigma around it as well. There's a judgment in the community. The uncles and aunties, anybody around them would come and say, why are you not taking care of them? But only the person who's going through this issue at that moment would understand that they would need some time. Number one, they would need to have financial backup while they are taking over the role as a caregiver. Number two, they need appropriate training, like Manvir has rightfully mentioned. You cannot just be a caregiver. It's not an overnight job. You cannot just take someone from the street and say, be a caregiver, especially if it involves things of high caregiving. People who have dementia, people who are bedridden, people who are on tube feeding. These are things that has to be regulated and it has to be done by someone trained. Yeah. So,
One more thing to that.
Yeah.
This is a gender bias.
Oh,
This
absolutely.
is absolutely gender bias, right? And what will happen is someone in the family is fallen ill, you people are going to look at you, what is your wife doing? What's your sister doing? And now it's 2026, heavenly, heaven sick. People go to work. They have their own careers. But their expectation is on the woman to do this. Very unfair, right? Very unfair. No, but they'll say, she can't say it, I will. She can. But the thing is,
Power.
So the gender bias is there because the family members do, your sister, ask your sister to do it. You understand? So it's very unfair to do that, and someone takes a back seat out of their career. I mean, if it's a short term, maybe something that they can do.
Might manage.
But
But
a longer
usually
term,
it's, yeah.
so it's difficulty there.
You know a lot about standard. You're on the board of
Yeah.
MSWH, right?
Yeah.
What about aged care and nursing home? Is there set of standards?
No, I think they are trying to develop it now. When I say they, I'm not sure whether it's going to be the Ministry of Health or JKM or who. This somebody needs to own this. Somebody needs to go into this space and say, this is our space. We need to do this, right? And I think asking the Ministry of Health to do it, is difficult.
Yeah.
Okay, because I think the Ministry of Health has its hands full. And what you just mentioned at the start of this, right? And you're talking about the healthcare systems. Now, if you look back at the history of Malaysian healthcare system, when we got independent in 1957, what happened was we just took what the NHS did and we transplanted it to Malaysia. Now, I am not sure, but I think our population then was about 6 million or 7 million people at that time. Now, it has grown. Our population has grown so many fold. You know, we got different issues lah. We got NCDs. That time where got NCDs?
Yeah.
That time you fall sick, you probably die lah.
Yeah.
You're not in a hospital. So we cannot, it's not sustainable for us to use that same framework. Because there's so many illnesses that are not catered for. And we are good at child mortality and all this because it was a plan that we look at it and say, hey, the levels are unhealthy for us. So we focused on that and we did very well in that. But you know, we really need to look at the entire infrastructure and say we need to change this. Because in that infrastructure, we don't have aged care. Because when we transplanted it for NHS,
it was for acute reactive medicine then.
Exactly. So there's no preventative health.
Yeah.
And there's no aged care health. You look at Singapore, you look at the blue zone cities in the world. There's 6 blue zone cities, right? Okinawa and Japan is one. But Singapore is an engineered blue zone city. Engineered because you have to take the MRT to go somewhere. You have to do this. And they have all engineered the thing. So the social determinants of health help you become more healthy.
Yeah.
The social determinants of health, the health ministry sits down with urban planning and say, okay, this is a condo here. So there needs to be a park here. Now, in the park, people need to walk, right? Now, but old people can't walk far, right? So every 200 meters, there's a chair. So you can at least walk 200, rest, talk to your friend, walk another 200, rest. But if you don't have that, will the person go and walk? No, I can't make it.
No.
Right? So this is how you enhance the facilities all around to keep people healthier. Because at the end of the day, the older you get and the healthier you are a benefit to the country because you've got wisdom, you can work, you can do all these things. Right? But if you're sick, you're taking from the system. So what happens is our system is not built for these times.
One man job.
Yes, it's not.
Yeah.
That's why it's called social determinants of health. So, you know, you need your water, you need a lot of these things, climate, all these things need to work into that. But somebody needs to take the lead and that needs to be the health ministry.
Yeah.
But having said that, you look at these countries that are the 6 blue zone cities that I'm talking about, and especially with Singapore, they have people in the Ministry of Health who specialize in this. They are not doctors. They went, they studied, did their master's, PhD, and this is their bread and butter. So they know that when I'm sitting down in the room and we're doing this, I need to call that fella, I need to call that guy. I'm not thinking of things from a clinical point of view. Because doctors are great, but doctors can help save person when you're sitting right across them.
Yeah.
Right? I can give you your medicine, I can check your blood pressure, all these things. I can diagnose you. Now, 500 people sitting outside, 5 million people in the city, that's what their skill set. But these other guys who have been studied and that is what their bread and butter is. So we have to pull them into the ministry to start thinking of how this entire framework and infrastructure needs to work.
Yeah, so we've got, you've touched the topic of NCDs. Okay, that means earlier the national health policies were directed towards managing the acute condition of NCDs. However, probably a success story in a way is that yes, we do have a lot of deaths due to NCD, but we also have a lot of people living with these conditions.
Yes.
That means we have managed to prolong their lives. However, their lives are not perfect. They are not as healthy as they are supposed to be because they have NCDs. Okay. So you talk to patients navigating specialists. Okay. So how well do you think our system coordinates care for someone with 2 or 3 NCDs? Because we always say tiga serangkai. Okay. Diabetes, hypertension, cholesterol, cardiovascular diseases, they come together. Okay. Metabolic syndrome. So one of the aspects of caregiving is actually medication management.
Right.
Okay, that means someone who is uneducated or someone who already suffers their own, vision issues or cognitive issues, they can't manage their own medications. Moreover, to manage another person, so they cannot be a caregiver. So, in order to be a caregiver, they have to be trained in medication management. So, if they are not trained, then there is room, margins for errors, miscommunications, duplicated tests being done.
Yeah.
What is your opinion in these conditions?
We don't have that system where it shares the information. I'm a patient. I was on dialysis for 10 years. Then I had my kidney transplant.
Okay.
Now, as a reason for being on dialysis for 10 years, 85% of the people who are on dialysis develop some form of heart failure. So I've got heart failure. So I go to 3 hospitals. My 3 doctors who know each other never talk to each other. The 3 hospital systems don't talk to each other. I am the carrier of my medication list. I am the carrier. So I go and sit down with my doctor at HKL and I say, okay, this is my test and IGN. This is all my result. Oh, okay.
Yeah.
Oh, okay. Then he puts it down on the system. Silo.
Based on your word.
Yeah. No. I give them the report. I give them the report.
Right.
Because coming back to some of my previous experience, I used to work in media, right? And I used to work in Formula One. So Formula One in the
Formula One.
in the 90s was full of data. Everything has to be data. All decisions were based on data, data-derived decisions, right? So now I'm the data. I am the carrier also of the data to go and give to my Dr. A. And then Dr. B and say, this is what Dr. A prescribed.
Yeah.
And then Dr. C.
You pass on the message.
Yeah, so I remember the incident a couple of weeks ago. My diabetes has gotten a little off this thing. So the pharmacist wanted to see me in HKL. So I go there and they're asking me, what medicine are you taking from this? And I have to go and show them. So from Serdang Hospital, from IGN, they go, oh, sana ada. Yeah. They have the data. But it's not in
It's
one
not integrated.
place. It's
Not integrated.
No, so when I lived in the UK from 2018 to 2020, just pre-COVID, right? And everything was very integrated there. It's absolutely integrated. It's what our current health minister, Dato Sri Zul, is trying to do is one citizen, one health record. That means it's unified among all the system. Now, Singapore has that. Hong Kong has that. It's brilliant in the sense that if you go to a GP clinic, they straight away have all your data. Oh, you're taking this medicine. Oh, you went and saw this doctor. Oh, so I'm going to input this data into it. Right? So that what happens is if you fall, you meet an accident, you faint, you are not in control of yourself, they can go and say, oh, this guy, they got all your data. Now, the doctors are dependent on me.
Yeah.
I am the carrier of the data.
Yeah.
What do you think is preventing us from having that kind of system? Is it because of legal issues?
No, we have been talking about it for 20 years. Other countries have just done it.
Yeah.
Let's try to get a perfect system. There isn't one. Right?
Yeah.
There isn't one. Let's be honest about it.
Yeah.
I like to think, unfortunately, that we have too many doctors thinking about this. This needs to be outside, because you have your Grab app.
Yeah.
Your Grab knows more about you
Absolutely.
than your hospital does. Something's wrong, right? So something's wrong.
The Grab, the Lazada, the Shopee.
Yeah, they know more about you and your habits and what you do than your hospital does. And that is something wrong with the system. So we need to get out of the hospital. Like you're doing this podcast, think outside the hospital.
Yeah.
We need to take
Beyond.
outside there, beyond that. Yeah.
Absolutely. One of the other aspects that we wanted to touch today was that nobody talks about aged care financing at all. Okay, let's go into that. Yeah, so there's no dedicated funding mechanism for long-term care in Malaysia. That means families have to pay privately, dip into EPF savings that was meant for retirement, or just simply provide unpaid care for themselves. So when a patient tells you that they cannot afford treatment, okay, so what is up next? Then there's some sort of incomplete financial navigation. There are schemes such as Pekabi 40. There's My Salam. However, there are still a lot of people that's falling through the cracks. Yeah. Is there such a thing as a missing middle in Malaysia? People who do not qualify. We had a discussion prior to the podcast that, we have this classification for financial status in Malaysia. We've got the B40s, M40s, and T20s, and then the upper ones. And you were mentioning that it's quite outdated. What's your comments on this?
So we've got a B40, M40, T20, right? The classifications were made 20, 30 years ago. It doesn't work today. And, you look at the classification for T20, which is the household income of 11,200 already hits 11,002 or 11,008.
Yeah.
So if husband earns 6,000, wife earns 6,000, 12,000 ringgit, you're already T20,
Yes.
Right. So two people are saying now, are they only two? No, they got two children.
Yeah.
How? They got two cars. They
It
must
doesn't
invest in a
account
house.
other
Right.
commitments.
So with $12,000, the government classifies you as T20. Do you really feel like T20? Do you have money at the end of the month? You understand? Because you pay your insurance, you do all these things, you pay your taxes at the end.
Yeah.
You have no money. So you classify as T20, but do you feel like a T20? And this is where we really need to look back at all these things and change it, review it, update it. You mentioned just now that, when Malaysia started, when we started in Malaya in 1957, what was the age of the people expected to live to? Maybe 50 something,
Younger.
60. Now with medicines, with all these things, you're talking about 80.
Yeah.
In this blue zone cities, they have 90,
Yeah.
100. So because medicine has advanced so much, people are living longer.
Yeah.
So are we telling ourselves we need to kill our elderly? No. Obviously not. We need to take care of them, but the system to take care of them. And this is where I believe in a social health insurance that everyone needs to pay for. And so that this social health insurance, when I get old enough, I have access to it, right? And, NHS has this, national insurance, a lot of countries in Europe. I think one of the better health systems is France, because I think you pay 60 to 80 euros every month, regardless of it starts at that, right? So what happens is that money is kept for you, right? And what happens is when you get older and you need to go into an age home, it's already covering that.
Yeah.
But that means the age homes have a standard, have regulations, certifications, all the standards. So you know that that money is going somewhere and you're going to be safe.
Yeah.
So we don't have to take out of pocket to take care of our family members, because there is that allocation which they have been paying for all their life.
Yes. Yes.
But as you mentioned just now, insurance companies cover up to a certain age, for example, right?
Yes.
In our country, they don't really cover aged care homes.
No.
So this is the issue that we have never looked at this frame,
Yeah.
We should have started this conversation 10 or 15 years ago.
Yeah.
Right. So as we are getting older, you all are quite young, but I hope that by the time you reach that retirement age, something is put in
Something
place.
is done, yeah.
Something is put in
Because
place.
it's quite concerning.
It's quite concerning to you. It's even more concerning to me.
Yeah.
You understand? And you look at my friends, my classmates, and all these guys, and hey, where do we go? Every time they go off to a home or something, they have out of pocket. So who's paying for it? And then you don't want to burden your family. Your family will be T20 6,000, 6,000 a month. But suddenly you have a family member staying with you.
Absolutely.
Who ill family member. Now the ill family member, you cannot take care. You have to put him in a home.
Yeah.
You have enough money, but you're T20 one.
But then that's the thing. When you get discharged from a hospital, I think the hospital gives a list of nursing care homes as an option. But from your perspective, you don't really know which one is.
Yes. So I think this is where the hospitals are doing the right thing. Patient comes, okay, these are the options.
Yeah.
But that hospital is not going to endorse They're just giving this information because you don't know. These are the available places around me.
Yeah.
Where you stay, you have to go and find. Because they dare not do that because there's no regulations on this. This is where we have dropped the ball.
Yeah.
We have absolutely dropped the ball on this. And unfortunately or fortunately, all our politicians are that age. They can afford to go into a well-to-do home.
Yeah.
But hey, they need to
How
start
about the
thinking
rest?
about the rest of us here, because this is a real life scenario, and being aged, we always want to take care of our elderly.
Yeah. So Manvir has rightfully mentioned the term we would highlight here is financial toxicity. So when someone is diagnosed with a chronic illness, whatever it is, okay, there's definitely going to be a few changes in their financial backup because they will have to now allocate their income, be it the patient, be it the caregiver. They will have to allocate certain income for medications. Then they will have to allocate certain income because they have to go out of their job for some time in order to focus in recovery and treatment. And then they will also have to allocate some amount of money for the side effects of living with the condition. That means if, say it's an example patient of cancer, then probably they'll have to go to chemotherapy, side effects of chemotherapy, side effects of radiotherapy, weight loss, hair loss, appetite loss, things of this sort. Then, for that, the dietitian would come in and give this milk and this milk and this milk, which is not cheap.
Yes.
Okay, every single thing associated with a chronic illness is not cheap, especially in Malaysia. When we speak about other developed countries, example, Australia, okay, say someone is diagnosed with a cleft palate from the time they are born. Okay, so immediately there's a support system available. That means through their national health insuranceing system, there is someone who's coming to provide the weekly tubes that's needed for cleft palate. There's someone navigating towards what happens next. A pediatric surgeon is involved. Everything is covered. Okay, whereas in Malaysia this is not. So when we speak about the aged care, the other term that we would like to highlight here is assisted living. Okay, so assisted living means we don't talk about only old people. We speak about people who are disabled. We speak about people who are post-surgery, be it a heart issue, be it an orthopedic issue, anyone who requires assistance. And at the moment, no insurancing system in Malaysia is covering this at all. Okay, so Mr. Manvir, back to you. If you could give one policy change or one mindset shift for Malaysians tomorrow, what would it be?
Okay, you brought up something fantastic there. When you give the example of Singapore, Australia, you said the word developed nation.
Yeah.
Now I'm going to back this a little bit up, right? I'm a WHO representative here in Malaysia. I'm a trained WHO patient advocate. The reason we need advocates, patient advocates, any rights, customer rights, everything, it is part and parcel of the UN Development Program, UNDP, to be a developed nation. We are a developing nation, right? So in order to be a developed nation, you need to have these advocates in there, bringing up the stories, bringing up the point of view of the consumers. And so what you ask me is, to answer that question of yours, right? What would I suggest is, the power is in our hands. Let me explain to you. We are the taxpayers. We are the voters.
Correct.
We are the consumers of this product, this system. We are the users of it. No. Why are we keeping quiet? We cannot expect the people to do something without us asking for this change.
Absolutely.
So this is where the patient advocacy, all this advocacy that we are doing, is to let people know about their rights, how they can improve it, speak to their MPs, pressure their ministers, pressure the people, because we want the change. Because I understand that being a doctor, if you are in the hospital system, you are part of the government, you cannot even criticize your own government. You can't even ask for something. Because, let's face it, seriously, if your boss doesn't like it, he will have you transferred to somewhere. You understand? This is a reality of it. But me, as the patient, all of us as patients, as users of the system, we can comment on it. Because we do when we buy a car, when we buy a phone, we complain what? But why is it when we take this healthcare, we are like, oh, we've been given this.
So we just accept.
So we have got to look at it from a very progressive point of view and look at ourselves. We are the users of this. We are the consumers of this. And you know what? I'm paying for it. No? I'm a taxpayer. And you know what? I'm a voter too. So I will vote for you based on what you're going to do for me.
Mm.
So if you don't listen to me, why am I voting for you? So this is the power that each and every one of us have. We have to realize it, and we have to ask, not even ask, but sometimes we have to demand for it. But when we demand for it, we need to have a good bunch of people around us who understand healthcare financing, who understand all these things. And we are sharing with you and say, hey, why is it Singapore is doing it, we can't do?
Mm.
Are we stupid? No. Why is it Thailand is doing it and we can't do it? Why is it Indonesia is doing it, we can't do it? Why is it Vietnam is doing it and we can't do it? Are we stupid? No, we're not. Our doctors are among the best in the world.
Yeah.
But is the system best in the world? I think so. Because what we're talking about here already, you can see the gaps.
Yeah.
There are gaps. We want to close that gap because one of the very important things is, Dr. Vignesh, that gap, somebody is going to lose their life.
Yeah.
And it is your father or your mother
Yep.
or your sister or your brother, or even worse, it could be your son or your daughter. And then you're going to be turning around and say, hey, what's wrong with the system?
Yeah.
So what we are asking you to do is communicate, speak, learn, understand the system. And we look at other, our internet is fantastic today. We can look at what everybody else is doing.
Yeah.
Like I can tell you that France has got one of the most mature health systems in the world. It's not America. America is among the worst in the world, right?
Totally.
But we need to look at what is good.
Yep.
How do we get there? How do we integrate those things? How do we take care of our elders? How do we take care of ourselves? How do we take care of our children? Are we going to leave this world in a better place or a worse? So, yes, we want to do that. Yeah. So this is where we need to share this. And this is where I'm telling people is know your rights, learn your rights, ask for help. You don't necessarily have. I know a lot of doctors like yourself that you work in the ministry, you work within and around the ministry. You love to work there. But then I feel hard when I see great doctors leave the healthcare system because they're banging their heads on a brick wall. And then I go to Singapore and do some work, and I see the public health specialist is having a God, he loves his work. And I go to Thailand, India, and I'm like, what are we doing? What are we doing here?
Do you think our public needs more empowerment in terms of awareness? The system that they're using and
absolutely.
For improving their rights.
No, we need to be starting to talk about how to improve these things, right? It's a step-by-step process, but that step one is understanding where you are and looking at something else and seeing, hey, what are they doing better? I mean, if you look at the cars in the world today, the Germans and the Japanese were leading the world. And then suddenly the China cars come in and people are telling me, hey, can believe her. I said, if the guy gives you a 9-year warranty, he's going to stick around, right?
Yeah.
Right. And you look at the advancements that they're doing, they are taking it and they looked at what everybody else is doing and then they say, I can do this better, I can do this better, I can do this better. And they're doing it.
Yeah.
Why can't we do that? It's a human thing.
Yep. As a country that can adapt to changes in various factors, I mean, speaking about cars, we have brought in a lot of EV cars, a lot of brands out there. We have worked with, countries like China. When adaptability is so easy in that aspect, why can't it be in healthcare reformation? Yeah. Why can't it be? So this is exactly the type of conversations that we should it should happen. It is beyond the walls of the clinic, beyond the walls of the hospital, and that is the whole point of this show. Building an actual community that is aware that aging and chronic illnesses does not automatically mean bankruptcy, does not automatically mean end of life. That means they should have a sort of a reassurance that, my government is helping me. If something happens to me, I do have somebody to take care of me. It's not like who's going to change my diapers in the next 6 hours. It shouldn't come down to that. Okay. So thank you so much for joining us today, Manvir. Yeah. It was an absolute pleasure having you here on board with Sihat Beyond the Clinic. Stay tuned for the next episode with Mr. Manvir Victor from Vital Signs Asia. Thank you.
See ya. Bye.